Hi, my name is Dr. Arsu. I'm a pediatric pulmonologist working at Children's Hospital of Eastern Ontario in Ottawa, Canada. Welcome to the session, Post-COVID-19 Care. So we have two excellent speakers today, and we will be sharing with Dr. Whitaker from London, who will introduce herself now.
Hi, I'm Dr. Liz Whitaker. I'm a pediatric infectious diseases consultant in Imperial College Healthcare in London and a senior clinical lecturer at Imperial College, where I do immunology research and been doing a lot of COVID work. So I'm really looking forward to these two great talks from our speakers. So thanks for joining us today.
Our first speaker is Dr. Zachariah, who is an associate professor of pediatrics and epidemiologist at University of Columbia and New York Presbyterian Hospital. So please, Dr. Zachariah, we are looking forward to your talk.
Hello, everybody. Thank you so much for having me. And I have a lot of gratitude to the organizers for inviting me to talk to you about post-COVID-19 in pediatrics. So when I got this topic, I was a little bit intrigued because I was wondering what I should talk about. And I know this is a combined session with an adult colleague. So I thought I would talk about what questions I get asked for children post-diagnosis of COVID-19. And these extend from pediatricians, sometimes from other ID doctors, and often from parents. And so some of these questions that I get once a child or a young adolescent has been diagnosed with COVID-19 include, are children different? Do they behave differently from adults who are infected with SARS-CoV-2? Are they infectious? And I know the special case of perinatal exposure, what happens to COVID-exposed neonates who are born to mothers with COVID-19 diagnoses? What happens with acute COVID-19? What is the symptomatology and how long does it take to resolve? Which is often a concern that many pediatricians and parents have. And then we will talk about post-COVID-19 sequelae. And the big one that I know that many of you are aware of and which we will focus quite a bit of our presentation on is multisystem inflammatory syndrome as it is known in the US. And we'll talk a little bit about other consequences. So the first question is, do children handle COVID-19 better? And I think the data is pretty clear. And, I think as some of us pediatricians were just chatting before the presentation started, this is one of the few silver linings of this terrible tragedy is that it has not affected children the way that it has affected adults. And there are many biological correlates and reasons for why this might be the case. And this was an excellent review which was published in PNAS, which summarized some of these. And these include the distribution of the ACE2 receptors, and TMPRSS2 is a protease which primes the spike protein to attach to the epithelium, and these receptors are underexpressed in children. The total balance between pro and anti-inflammatory cytokine expression, it is different in children, particularly levels of IL-10 and IL-13. The T cell reactivity in general, and whether the immune response is skewed towards a Th2 response versus a Th1 response is different in children. And that is one of the hypotheses that they might be responding better. There's a whole sort of theories around viral interference about previous infections with SARS-CoV-2 coronaviruses or even vaccine responses that might be protecting children in a way. And finally, we know a lot of the pathology of SARS-CoV-2 in adults tends to be vascular in nature. And the general healthier endothelium in children seems to predispose them to better outcomes with acute SARS-CoV-2. And the reason I think this slide is important is that this probably has relevance to delayed manifestations too, because when we talk about how they're affected, I think the continuum of how manifestations happen in COVID parallel what happens with acute COVID-19 too. So the first set of questions I did want to address were the indirect impacts of children. And this we get a lot of questions from parents all the time. I have a child who is positive for SARS-CoV-2. What is the consequence what is the consequence of the rest of the family? And this is a very controversial area. And there are many, I'm sure that it was covered in some session in this conference earlier, particularly around the area of school closures. But from my experience in New York City, I think we feel there's enough evidence to say that viral loads are pretty similar between adults and pediatrics, at least the ones who are hospitalized. And there have been a few papers, and even from our center, which have shown that relatively well-appearing infants can have very high viral loads. However, the clinical correlation in terms of infectivity with these studies is less known. It seems pretty clear, and there are reports and they're increasing, that transmission can occur from children to adults. But when we have studied the epidemiology of our cases here, and we've had around 100 to 120 hospitalized cases, this has not been the primary driver. I think most of the times we do have other infected family members, which were the index cases. I think for all these questions, local rates of community transmission seem key. So context is very important. And as time passes on, we're seeing more and more of these cases come back. And though we are on high alert for reinfection, which we have not seen yet, prolonged shedding is very common. I think we've seen up to now 6 months of positivity from an initial infection, but we have not seen any secondary infections with these delayed post-viral shedding, which happens in a small segment of children. The other quick slide that I will do, which is another question that we get about post-COVID infection, is what happens to moms who are exposed to COVID-19? And I'm sure there were OB sessions in this conference earlier. I just wanted to present some of our data that we've had many, close to 500 pregnant mothers, and we have not found many convincing cases of in utero transmission. We've had, in our 8 hospital healthcare system, we probably have had one very confirmed case, and this is a placental pathology from that case, which showed viral RNA. Initially, we started testing newborns at day 1, 24 to 48 hours, 5 to 7 days, and 14 days. And we have a group of very active OBs and pediatricians here who've been following these COVID-exposed neonates for up to now 4 months now, and matched the controls. And so far, there have not been any significant differences in development or neurodevelopmental assessments that they have observed. So hopefully that trend continues. So now a few quick slides on acute COVID-19 in pediatrics. And I think the reason I did want to talk about acute COVID-19 is because as you will see, what happens after an initial SARS-CoV-2 infection in children seems to be very different from adults, as the next talk will probably illustrate, is that children seem to present in discrete, groups. And I think distinguishing the ones who present really early with acute infection versus having our feelers out for the ones who are going to have delayed post-COVID sequelae is something that I think a lot of pediatricians and geneticists and immunologists are trying to work very hard on, and trying to have some predictive model. But I think, so it's very important to understand what happens in acute COVID-19. And I think this is like a bird's eye view of our summary of our US experience, which hopefully is the same as what has been reported in Europe. We have found that infants are admitted more to the hospital. And I think that partly has to do with the fact that the threshold for admission for somebody who's 6 months is a lot lower than somebody who is 15 years. But in our experience, they have not had very severe respiratory disease. Older children and adolescents have worse respiratory outcomes. The vast majority of children who have been hospitalized have had medical comorbidities, and risk factors that are, being increasingly reported in adults align with those in adolescents, which is obesity. I think the kids, and I think this is something that's very important for, I think, pediatricians to understand, is that the children who have manifestations from COVID-19, severe manifestations, seem to be a very self-selecting group. And I think once they're within the medical system, I think you have to be very careful about how they're going to progress. Because I think once you're in the hospital, our rates of ICU admission have actually been quite high, which is around 30%. But luckily, our mortality rate for acute COVID has been less than 1%. So this is our initial paper, which we published in JAMA Peds, and which I think has many of the observations have been borne out with other papers after this. We have found that increasing obesity is the most common risk factor in children who are, or adolescents who are otherwise medically well. There were some big surprises, and I think this has implications for post-COVID guidance that we give. We found that immunocompromised children and children with asthma did much better than we thought they would initially when our a pandemic started. In terms of outcomes, they really did not do worse. And I think one of the consequences of that, which we're still trying to tease out, is how far should we postpone care for a child who, for example, who needs chemotherapy or is due for a transplant, who has initial COVID-19 infection. And the practice so far, at least initially, has been to delay till they're COVID negative and give them quite a few number of weeks from the initial infection. But I think that the risk benefit of that we have to constantly address in terms of post-COVID care. We found that the admission and the length of stay is usually bimodal. Usually they stay, they get better really quickly, and they go home within like 3 to 5 days, or they get intubated and they have ARDS and they stay for 2 to 3 weeks. We have looked very carefully at the initial hospitalizations for COVID-19 now that we've had around 3-4 months to follow them up. We have not had any readmissions for, I would say, acute COVID-19 phenotype of symptoms. Like we have not had any recurrent ARDS or recurrent respiratory infections. All our readmissions for that cohort have been for non-COVID-19 related care so far. So current recommendations, this has probably been covered in the PED session. We feel supportive care is probably the most important in most children. Severe illness is defined by supplemental oxygen requirement. We do remdesivir. This is from the Pediatric Infectious Disease Society. Most of our kids have tolerated therapy quite well. We do immunomodulation for late disease based on some of the data from adults, and we treat co-infections when they arise. But I know that is not the focus of this session. So one of the things that we have found when we started looking at acute COVID-19 and when we started seeing the delayed presentations with multi-system inflammatory syndrome is that we did find some cases which overlapped. And I think one of the things that helped us is that we had a completely naive population in the first month of the pandemic, because once it was introduced in like February to March. So we did have, and I will show you some data with the biphasic response, we did see some overlap between presentations between the acute and late COVID-19. And these are some acute presentations, which I think can also seem to happen in the post-COVID type of phase. We have seen severe pharyngitis and odynophagia. Many of our children seem to have present with appendicitis type syndromes, and even in the initial phases of the pandemic. And I think there's one paper from Texas which had pathology from one of these children which showed SARS-CoV-2 related inflammation, vasculitis in the appendix and not acute appendicitis. We've seen new onset ketoacidosis. We don't know if that's related. And most of the times they have some mostly benign elevations in the coagulation parameters, but acute thrombotic events are rare. So now to the meat of the talk. So we kind of know what happens in acute COVID-19. What are the presentations of kids who present and get really sick with acute COVID? So what happens after that? And this is like $1 million question, which I think, again, I think the adult, my talk from the adult medicine colleague would probably illustrate it more in the older cohort. But our experience has been so far that children who are infected with COVID-19, particularly those without very severe infections, resolve completely. So we have done some follow-up studies, and some of our cohort studies are still ongoing in terms of follow-up for the severely infected cohort. But one we have completed is looking at infants. We followed infants till symptom resolution and up to 30 days post-symptom resolution. And we found that most infants had symptom resolution within a week, within a median symptom duration of like 5 days, with the interquartile range of 2 to 9 days. And on follow-up, most of them did not seem to have, acute sequelae from SARS-CoV-2 yet. But as I'm sure the pediatricians in the audience will know, a month is, a big, 6 months is a long time, and 1 year is even longer in terms of when you talk about childhood. So we do need regular follow-up studies for many of these cohorts. As I mentioned before, readmission has been relatively rare for us, and it's mostly for unrelated causes. Now, something we noticed very early on, and I think this illustrates something that has been quite different, I think, in pediatrics versus adults, is children with COVID-19 seem to segregate themselves into multiple buckets. And I think that it is the children, and this is some data from our center, which we looked at ED presentations across the first 10 weeks of the pandemic. And we started with looking at, clinical presentations in our pediatric ER. And some of the things we noticed was that, after around week 5, we had this sudden jump in fever as a high as a presenting manifestations of children who were diagnosed with SARS-CoV-2, and hypoxia almost disappears as like a presenting complaint. While at the same time, you can see a gastrointestinal, this is the yellow and the orange, and mucocutaneous manifestations and neurologic manifestations completely increasing in the second phase of the pandemic. And, correlated with that was the, laboratory markers, where you can see a biphasic trend in inflammatory markers, where you can see the second set of children really had very high inflammatory markers as compared to the first set. While when we looked at the viral load, which was the inverse of the cycle threshold values for initial PCR values, they went down. So it seemed pretty clear to us. It was not this did not seem like the same children were presenting twice, since we did not have any overlap between the first and the second cohort, but it was a distinct group of children who were presenting with delayed manifestations from an initial SARS-CoV-2 infection. And this is just a graph showing the presentations at our center, which shows 3 to 5 week lag time between the initial presentations and inflammatory manifestation. So I think post-COVID-19 infections, and there was an excellent paper from the CDC where they tried to do clustering for these delayed COVID-19 manifestations. And I think the general consensus seems to us, based from our experience, is that they cluster in 4 groups. One is typical MIC, which is usually gastrointestinal symptoms and profound cardiac dysfunction. Then we have MISC, and this is a controversial group where there is some overlap with either complete or incomplete Kawasaki disease, and whether these are the same thing versus completely different phenotypes is something that I think a lot of controversy exists right now. And then the other thing that we have seen is isolated end organ involvement, which we're tracking now in this cohort of children who have had positive antibodies without any other features of MIC. And again, and now this is something that I think every day there's something in the lay press about prolonged symptoms post-COVID-19, which I think is now quite well described. And I think my colleague will have more about this in the talk in the adult population, particularly in older people. But we're trying to see whether this exists in pediatrics. MIC, a few broad outline. It does parallel the general rates of infection. Like the disparities that exist in acute COVID-19 seems to be occurring in post-COVID-19 manifestations too, which is something all of us as ID physicians and doctors, I think we need to think deeply about. Most of them, very different from the acute COVID-19, most of them seem to be previously healthy. And intriguingly, obesity seems to pop up again here, which we don't know, is it because it's because the underlying population that's being infected, or is it something physiological? There's a very high rate of ICU admission in this population, even higher than acute COVID-19. Our current estimate of coronary artery aneurysms based on many studies is around, I think 10%. ARDS and respiratory symptoms are uncommon, and most of the children that are respiratory who have been intubated at our center have been intubated for cardiac reasons. Mortality is low. So this is a paper that illustrates, I think, what I mentioned before, the clusters, which this is from the New England Journal paper that we contributed to. So we see younger people presenting more, younger kids presenting more with KD and incomplete KD, where the older children or adolescents present with more myocarditis and more typical features of what we would say is MISC, gastrointestinal symptoms, and profound cardiac hypotension. A big question that that we are tackling now is we get a lot of questions from pediatricians where we've had a kid we know has had COVID-19. Is this kid going to develop MISC? And is there a way to predict which children are going to develop this later? So we have looked at our center at the kids who presented at the same time in our outpatient settings, and we never got diagnosed with MISC. And long story short, it is quite hard to, I think, diagnose, because one of the big things that we noticed is that none of the kids who came in with MISC had medically attended acute COVID-19 visits. So it was not like they were coming into the healthcare system to get treated or be seen for acute COVID-19, and then you could do follow-up for them. So they had very clinically inapparent infections, or it was a slight cold. So that makes it harder. Many of the kids, I think the only difference, as you can see, this is looking at some graphs comparing the febrile kids and seen in the outpatient without MISC versus others, is that they had really high fever, which did not remit till like day 5. They had multiple concurrent symptoms. So they usually had like conjunctivitis and rash and fever. So it was never usually just fever. And it was relatively rare. Again, I think this is something very reassuring for parents that despite, there's so much lay press on MISC, the vast majority of children who were febrile during the acute MISC peak for us were actually fine. So, which was comforting in many ways, but makes it very hard to distinguish. So other labs that we can look at are very high BNP, high CRP presentations. This is a paper from CHOP, which showed lower TNF alpha and IL-10 in MISC cases compared to severe acute COVID-19. They do have low viral thresholds on the labs, and they do have some more features of microangiopathy on features. So management, I won't stress too much. I'm sure you had an entire session on this. I would just, since we're ID physicians on, please have a robust approach to differentials. We have had cases which were misdiagnosed as MISC and had toxic shock syndrome. So you need to have ID input. Antivirals are not routinely recommended since it's biphasic. Most of our children have gotten immune IVIG or steroids, and we use biologics only for refractory cases, okay? So these are some of the instances biologics we have used. One thing to remember, and particularly for having a reason to have immunologists involved, is that we have seen phenotypes of acute delayed COVID-19, which have gone from typical MISC. For example, this kid who started having initial MISC, but ended up having acute renal failure and had microangiopathy on the biopsy, and had elevated complement and needed to be treated with eculizumab. So not every MISC is the same. It's sort of, I think it's something that I think we should remember. Long-term follow-up studies are ongoing, and we followed up kids now up to 6 months. And this is our panel. We do repeat COVID serology if they were negative. We do repeat echoes, cardiac MRI only at 6 months if they have delayed function, basic sets of labs, and we with CBC, with DIF, troponin, and proBNP, T-cell panel for the immunologist, and we taper the aspirin and the steroids. So early follow-up data is just very encouraging. More than half of these patients have recovered myocardial function. And then of the 75% who we have follow-up data on, the vast majority have regained normal echo function. and they apparent otherwise are well. We've had only one child who's had prolonged depressed function at like 4 months. So one thing to remember about other delayed manifestations we have seen at our center, and this is outside of typical MIC, we've seen thrombocytopenia, we've seen some acute neurological manifestations with transverse myelitis, 6-nerve palsy, and persistent headaches, but SARS-CoV-2 has been mostly negative in those cases. Now, this is something that I think my colleague will talk more about. We have not seen persistent long-term symptoms yet in children, and we hopefully will not see that. But we have ongoing cohort studies to illustrate whether there are more significant factors. And I think these are going to be the most important things that we will, as pediatricians, have to deal with more than the acute medical manifestations. Is the psychological sequelae, impacts of disrupted schooling, vaccine delays. We had an epiglottitis last week from Haemophilus, and food insecurity and higher rates of obesity. So this is my summary. Most children do recover and do not have sequelae based on current evidence. Delayed manifestations seem to be very distinct, and these are medically attended. Immune dysregulation seems to be key, and both these acute and delayed severe presentations and disparities have to be addressed. Thank you very much.
Thank you, and thank you very much to Dr. Zachariah for that really fascinating talk, and we look forward to questions at the end. So just to let everyone know that we're going to run straight into the second talk and then do a session of questions for both speakers after that. So I'm delighted, so maybe you could unshare your screen, Philip, that would be very helpful, thank you. I'm delighted to present our other speaker, who's Angelo Carfì, who's a geriatrician from Rome, whose pre-COVID life involved medical practice and research into adults with intellectual disability and cognitive impairment and mental health. And during COVID, like all of us, stepped up to look after adults with COVID and has published on adults with persistent symptoms post-acute COVID, which I know many of us are very concerned about. And I'm sure we all have colleagues and friends who've been affected. So we really look forward to hearing your talk. Thank you.
Thank you very much for the introduction. Can you hear me? Yeah? Okay. And I would first of all like to thank the scientific committee for inviting me and for allowing me to share some results from our group. I am one speaking here, but I speak on behalf of many colleagues that together with me started to and push forward our post-COVID practice in Rome, Italy. So, no, this is not working here. Okay. So this is what I'd like to talk about. Let's give a brief introduction to the topic, which will be very, very brief, and then to share some of our experience and our results. So since the early days of the summer, there has been much talk about the so-called long-lasting symptoms of COVID-19. And science journalists and columnists of major newspapers have begun to tell stories of people who were struggling to return to their normal state of functioning. Despite the great media interest, both the scientific knowledge acquired on the subject so far and the availability of data are still at an early stage. So here I just show something, but there are a few good quality data. On the left, for instance, I present this representation of the answer given by more than 1,500 people to a survey organized by the University of Indiana. And on the right, for instance, there's an English study that is starting to recruit patients to thoroughly ask the question, what's going on after COVID-19? And they're planning, it's coordinated by the Leicester University, and it is planning to recruit more than 10,000 patients after acute infection of COVID-19. There's also other reports from the UK and Germany, and also from the CDC, and every week some new report comes out in the media. So This is our contribution, is a snapshot of the paper that came out on JAMA on July from our center. And it shows data from 143 adults which were assessed in our post-COVID practice at about 2 months from the beginning of COVID-19 symptoms. And here we were able to show that a high proportion of patients presented with fatigue, dyspnea, and pain, as you can see here in the upper part of the graphic. So I'd like to start from here and show some update on this study with some fresh data. And I'll also try to show if there's some important differences between old and young subjects, and show also some preliminary data on neurological symptoms related to COVID-19. But before I describe the methods of the study, which are actually very, very simple, I would like to briefly spend a few words on how we came to conceive this work. So during the pandemic, most of us worked in acute wards for COVID-19. And after seeing the clinical impact of this disease on our patients, upon discharge from the ward, we naturally wondered what would happen to them and whether and how they would recover. So our leaders wanted to venture into organizing a day hospital to reevaluate these patients. And surprisingly, a plethora of specialists made themselves available to offer the most comprehensive clinical evaluation possible. And at the same time, it was also possible to organize both a standardized clinical approach and a data collection system from the very first days. I say all this because in this sense, ours was born not as a clinical study, but as a medical practice, which collected data like in a clinical study. And this is important, so you can take this as a sort of maybe a general limitation of all the data I will be showing. So most of the patients enrolled at the beginning were contacted by the discharge lists from our hospital, but later other people from the local area were also added to the study. So this starts as a practice, medical practice, to offer patients a follow-up. But we gained the data on the way we were doing that. So the methods are very easy. You needed to have an established diagnosis of COVID, and you also needed to have met the WHO criteria for the release from the quarantine. And a third inclusion criterion was to have been negative to an additional swab performed at the first visit in the day hospital. So we retested everybody. This was strongly suggested by the direction of the hospital for the safety. So what happened once the subject was in the study? Everybody undergone a number of evaluation by many specialists under the coordination of a team of internists and geriatricians. And specialists included ophthalmologists, ENT, pulmonologists, angiologists, cardiologists, rheumatologists, gastroenterologists, neurologists, and psychiatrists, to name most of them. And so for each person, we collected an enormous amount of data from evaluation instruments, as detailed by this methodological paper that I am showing here. So this is the updated pyramid from the article in JAMA, now with 335 patients enrolled. The average age is mostly the same, 55 years. And as you can see, the rate of persistent symptoms is quite the same. But the result is not obvious because the average time that elapses between the onset of symptoms and the assessment in the day hospital was increased by about a month. So there's no specific reason for this. Is that the practice? It's technical. It's a technical matter. We had the summer in between, and it was more difficult to get the patient coming. So now let's see how the data look like by stratifying the sample by age group. So we have 1/4 of the sample, which is over 65 years of age. In the upper right corner, there's also a histogram showing you the distribution of age. And there's no surprising differences in the general parameters. As you expected, the years of education are a little bit lower in the group of the elderly. And the relative frequency of anti-influenza and anti-pneumococcal vaccination are higher in the elderly, because in Italy, these are reimbursed services for the elderly. And in this slide, you can see that the clinical features before the COVID-19 are completely different, but this is not unexpected. So cardiovascular disease, diabetes, renal failure, chronic bronchitis, thyroid disorders, and cancer are much more represented in the group of the elderly people. And there's also some differences in the smoking status. Okay, here's a table with some important aspects of the care received during the acute infection. So the differences are substantial. The ventilatory care was needed in twice as many cases in the elderly group here. You can see the figures are mostly double. And similarly, the drug therapies were more aggressive, more required in the elderly. You can see antiretrovirals, hydroxychloroquine. In the beginning of the pandemic, we were giving all we had in the warehouse. So and also the hospital stay is a little bit longer. So all this seems to indicate a more difficult course of the disease, which is what we learned from the news, and it's reflected in the data. But despite this, the number of persistent symptoms or the perception of the loss of quality of life were not significantly different between the two groups. Okay, let's see now. This is like the pyramid in the JAMA study, but it compares the young and the elderly. And this is the acute symptoms. The young group seems to show a more symptom-rich type of clinical presentation. Notable differences concern headache and osteomuscular pain, sore throat, and the gastrointestinal symptoms. And in this other one, we show the differences between the young and the old after in the recovery phase. Important differences seem to be between joint pain, cough, and sputum production, which are more frequent among the elderly here. You can see the bars here are bigger. While muscle, chest, and pain and headache are more frequent among the young. Here. So these are mainly the differences. Now let's have a look at the neurological symptoms, which are also have a lot of resonance among the media. But rigorous scientific data are not yet available. So it's quite well described in the newspaper, but we need to have good quality data. And at our hospital, the patient received a thorough neurological evaluation through an accurate medical history and the administration of a battery of neuropsychological tests. Here I show this inverted pyramid, which I inverted by mistake, but anyway, the data are proper. And the neurological that describe the neurological symptoms, the disorders of sleep, memory, and attention that you see here in the blue box are present in 1 in 3 patients. And this is a quite striking result, taking into account that we're seeing this patient on average 2 months after infection. In this bar plot, we show the history of each symptom. So in the bars, you see the neurological symptom, and you have different possibilities. So no symptom, the symptom that existed before the COVID infection and was not modified by the disease. The symptom was present during the acute phase, but subsequently resolved. And then we have the pre-existing symptom that was worsened by the infection by SARS-CoV-2, and the symptom that started with the disease and didn't heal, this one in purple, and late onset symptoms. And here I highlight, here you can see that in about 1 in 5 patients, the COVID is leaving marks, in particular on sleep, attention, and memory domains. So this is what the patients reported during history, but the neurologists managed to do the neuropsychological tests, which I show you here. So although it looks extremely bizarre, I decided to keep this graph anyway. So each column in the x-axis represent a different neuropsychological test. The y-axis has the normalized score for each neurological test, and each point represents the patient scores. The red points are those patients who referred some neurological problem after COVID-19, and in dark triangles are people who refer to be completely okay. And values, scores 2 and from 2 and below are considered to be pathologic. So without getting into the details of the neuropsychological tests, I'd like to highlight 2 points. In the red box, we see all these red points indicating subjects that claim to be feeling bad but perform well in the test. So all these dots are patient feeling bad but performing good. And in the black box, these triangles is persons that claim to be symptoms free, but when tested, they have pathologic performance in the neuropsychological test. So this is the same thing shown in a different way. In the upper panel, we show results from people who refer to be okay, who refer some problems with after COVID-19, and these ones are those who say that everything is okay. You can see that independently of what they say, when properly tested neurologically, we see a lot of pathologic tests. And I want to stress that this is from the working memory domain, so recent memory, memory for procedures, and this is for attention. Okay, so this could be some of the first data available from a neuropsychological test that confirms what the newspapers say. So people has a sort of feeling of foggy brain. And I wanted to also, since the topic was to distinguish between younger and elderly, the same thing, the same pattern applies also to, there's no big difference between younger and older people. So let's do some summary. The persistent symptoms are present even in bigger sample, evaluated on average 3 months after the beginning of symptoms. Despite the more difficult course of the disease, persistent symptoms are not more prevalent in the elderly compared to the young. Joint pain, cough, and sputum are more frequent among the recovering elderly. Headache, muscle and chest pain are more frequent among the young people. And then sleep disorders, memory and attention problems are reported as frequent as of 30%, and neuropsychological tests show an unexpected pathological result in the attention and memory domains in about 40% of the subjects. Thank you very much.
Thank you very much for this wonderful talk. So now it's time to answer some questions that were posted by the attendants. And so far we have 5, so please, feel free to post your questions. So I'll start with asking the questions to Dr. Zachariah. So the first question for Dr. Zachariah was, is there any data regarding the occurrence of pulmonary fibrosis in pediatric patients?
So I think the question is probably, is there long-term sequelae of having SARS-CoV-2 infection? And I think that, one of the reasons for that is probably there's a long history of viral infections predisposing you to wheezing and bronchiolitis and worse outcomes later. So we have been looking at that, and I don't think what we have seen so far is that we have seen children who've had very clinically inapparent SARS-CoV-2 infections previously, presenting later with acute asthma exacerbations, who have very clear-cut radiographic signs of severe SARS-CoV-2 infection. So we don't know if that is because of, and they get treated for the SARS-CoV-2, they get treated for asthma and go home. I don't think we know yet whether that's because of some long-term lung remodeling type of inflammation that has been set off by SARS-CoV-2, versus it's just radiographic findings which are just persisting post the acute infection. But I think that's an active area of inquiry, whether, does even having, clinically non-significant SARS-CoV-2 predispose you to later pulmonary outcomes first, but we don't think we have the data yet.
Thank you, that's fair. The second question to you, Dr. Zachariah, was, are there kids who were tested positive, who were initially asymptomatic, and then developed MISC?
Yes, I think that is one of the challenges with, identifying MISC, is that the first infection can be very clinically inapparent or very mildly symptomatic. Now, we didn't, most of our cases of MISC were never seen in our clinic for acute COVID-19 infection. So, and for at least, I would say 30 to 40% of them, there was no clinical history suggestive of. Of course, this is based on recall. There's probably a recall bias with the family thinking of, there was a family history of COVID-19 in some of these cases, but the parents couldn't remember symptoms of acute COVID-19. So, as I said, the immune response seems to be delayed, and it seems to be happening later. So the answer to that question is yes. So we'll have to figure out a better way of finding out which kids, when they get infected, are more likely to get MISC.
Okay, I thank you. And now I will hand the microphone to Dr. Whitaker to post other questions.
I completely agree. That's been our experience as well, that the children really didn't have any evidence of severe disease before they presented with MISC. So Angelo, that was such an extraordinary comprehensive data set that you're collecting. So congratulations to your group. There are a few questions here. The first one is, do you have any idea of the incidence of post-COVID fibrosis? And I presume that means lung fibrosis in the adult patients?
Yeah, our radiologists which are involved are scheduling CT scans for our patients, but I need to upload the data right now, because for imaging, yeah, you need some data crunching before making that available. But sure, we will have it. And
are you doing lung function testing as well, or just imaging?
Sorry, lung?
Are you doing spirometry or any lung function testing?
Sure. Yeah, we have those data, and also yes, I didn't show it because I need to talk about that with the lung specialists. And from a rough preliminary check, you know, the DLCO seems to be the most important parameter that could be affected in this patient. So the permeability of the membranes. While the other tests, at least the last time I looked at the data, were not much affected.
Well, we look forward to seeing it when it's ready. The next question is that, do the inflammatory markers persist or stay higher in those patients who have persistent symptoms?
I didn't have the chance to look at those data. Right now we have a C-reactive protein in our data set, but we don't have other, like TNF and IL-6, which should be uploaded in the next time. And I didn't have the chance to analyze those data. I'm sorry about that.
No, you're presenting a work in progress. It's a huge thing you're doing. So thank you for showing us your methods. So you mentioned in your methods that you excluded patients who'd had fever in the last 3 days, I think. But one of the questions is, did you see persistent low-grade fever as a post-COVID-19 symptom? And I don't know if you would include those patients in your cohort.
We are not tracking for this very smoldering and very low fever. So at the beginning, we were very much concerned about the safety of the specialists who would assess the patients. So you needed to have no fever completely, and you were retested with a further swab to be negative. So I cannot answer properly. Most of patients didn't report any fever.
Okay. And then somebody is asking, did you detect any new onset diabetes in patients recovering from COVID-19? So I might quickly, as a pediatrician, we've had an observation of new diagnoses of diabetes in the pediatric cohort, but we do sometimes see clusters at other times, so it's hard to extrapolate directly. And we've certainly seen very late and severe presentations with diabetic ketoacidosis in our population. But I wonder, have you seen that in the adult cohort as well?
We are having the endocrinologists who want to be involved in the study, and it's work in progress. I apologize.
No, we look forward to the next meeting when you can tell us all these things. It is such an important question, and it's good to do it properly and to be comprehensive. So it's great that your team are doing this. Do you evaluate post-infectious dysautonomia in the adults, or is there evidence for this in the field? Dysautonomia, so I think the blood pressure and heart rate and the autonomic nervous system. I'm demonstrating that I'm an ID person here. Help. So do they have hypotension and hypertension that's changing rapidly, the blood pressure and heart rate?
Not as far as I know. We have a thorough vascular evaluation. We have the angiologist who does the endothelial reaction tests with the pressure cuff, and with the echo scan of the of the vessels, but we didn't analyze those data yet. Maybe that group is already analyzing it, but not me right now.
So one person asks, if you have the same pattern of results in people that complain of symptoms and those that don't, how can you tell you're not describing pre-COVID function impairment? So I think they're saying is, how do you remove any bias in the assumption that it's COVID related rather than being something else?
Yeah, this is a limitation which we should live with, because we didn't have the proper neuropsychological tests for this person, which were completely healthy as far as we know before COVID. So the important part is that yeah, it's tricky now to figure out how to try to separate the two groups, because as I showed, people recollect something, and then they complain for something, but they then perform pretty well, and the opposite. So it's a little bit tricky. We have to think about that.
You have a big enough number, I think, that those things might balance out. How long are you planning to follow the patients for?
The practice is open right now, and they are enrolling. The plan is to enroll 8 persons, new subjects every day.
Gosh.
And we are going to go ahead. And actually, what we should do is to longitudinally study the same subject, which is not in the plan right now, but this is what
the
we
next
should
grant.
be doing. Yeah,
the next funding opportunity. So I have a question that's maybe a bit unfair that I'm asking, which is, I don't know if you heard this morning in the UK media that they're planning on doing human challenge studies for COVID-19 vaccines in the next few months. So this would be where participants who volunteer and consent receive the vaccine and then are challenged with the COVID-19 virus. And given that your description of these really persistent symptoms, I wonder how you feel about that, or to the other panelists.
Well, it's a challenging question. The point with COVID is that it is completely unpredictable, and we, as far as I understand, I don't think myself as a big scientist, but we are not getting the real point of the infection and what this virus does to our bodies. So maybe could be not that safe.
I think that there are questions that are best answered by these types of studies, but I wonder if perhaps we need to know a little bit more before we do these types of studies. But it's an interesting time. I think that's probably nearly all our questions, and we have 2 minutes left. So I think maybe we should draw a close there, unless anybody on the panel has any other questions. Nope. So I think we'll say thank you very much to Dr. Zachariah and Dr. Carfì for 2 really fascinating talks and great discussion afterwards. And I think that we've all learned so much. It's been a fascinating and terrifying time to be a clinician during COVID, but that by communicating like this at conferences, we all learn from each other. And we really look forward to hearing further results from you in 2021, if not sooner.
Thank you very much.
Thank you.
Thank you.
Bye.